Alaikum, Wadid, are you there?
Hello.
Professor Steven, welcome. Professor Mulazam Hassan Bukhari, how are you, sir? Very nice.
Nice
Thank
to
you.
see you.
Oh, thank you. Happy to see you, sir. Happy to see you. You are, sir, you are a young man, sir.
Hardly.
Okay. I am 70-year-old. My age is 70 year.
I'm 60.
Okay. Today my son called you, I think.
Yes.
Okay. Well, yes, he is.
I sent you an email, but I don't know if you were able to access it.
Just I came from meeting and inshallah I will check the meeting inshallah. Inshallah.
Okay.
Hopefully you will enjoy the Pakistan. Your first time coming in the Pakistan.
I'm looking forward to it.
Uh, and even Anil is also coming.
Oh, great.
Anil is coming. And you know Ijaz Nasir?
I believe so, yes.
Yes, he was telling me that when you are doing a fellowship, I think dermatology, he was also there. He did the fellowship in neuroendocrine.
Okay.
Okay, I remained with him in University of South Florida, Tampa. I did my postdoc in research
Oh, great.
in I think 2018. But I love Pakistan. I have not applied for visa or nationality because I love Pakistan.
Good.
And I think 7 minutes are there that students, inshallah, they are waiting for.
Okay, let's see. You want me to test the sharing of my screen to make sure it works?
Yes, can you share?
Yeah.
To-
All right. Can you see the lecture?
Join, sorry. All okay, yes. Yes, Professor Stephen, yes.
Great.
Where it's clear.
Good.
Uh, Wadid, you are there? Mr. Wadid? Mr. Wadid, are you there? Hello, Wadid, my IT personals.
And we'll have to figure out a time for me to do the other parts of the lecture.
Hello, Wadid, you are there? Hello? Hello, Dr. Farwa.
अस्सलाम वालेकुम सर।
फरवा कैसे हो बेटा?
अल्हम्दुलिल्लाह सर, अल्लाह का करम, शुक्र अल्लाह की जात का।
ये
आप ठीक हैं?
मैं डॉक्टर फरवा, डॉक्टर स्टीवन, डॉक्टर फरवा is my secretary of the PAP. She wrote you the letter, Dr. Farwa, Professor Farwa.
Nice to meet you.
Dr. Farwa, I think, have communicated with Dr. Steven, I think.
Yes sir, I communicated with Dr. Steven. Welcome Dr. Steven to Pakistan. Nice meeting you.
Nice meeting you. I'm looking forward to my visit.
Dr. Farwa, in the beginning, I asked Dr. Steven to give one lecture. And he sent me the message, Bukhari, I'm not feeling satisfaction. It is not justice that I come in Pakistan for only one lecture. So that is why his greatness. Now we're getting more and more benefit from Professor Steven.
Thank you so much sir. Thank you so much sir. It's
Hello.
really an honor for us.
I'm happy to do it.
थोड़ी देर join. नहीं, डॉक्टर फरवा कर लेगी। नहीं उस अच्छा अच्छा अच्छा, उसमें सिर्फ मुझे करना पड़ेगा या डॉक्टर फरवा भी कर लेगी? डॉक्टर फरवा ये एडमिट करते जाएं जो भी आए हैं। अगर मैं बिजी हूं ना तो जो भी शामिल होता जाए ना उसको वो।
Right, sir.
डॉक्टर समीना, हाउ आर यू? डॉक्टर समीना कमर, अस्सलाम वालेकुम।
जी सर, अस्सलाम वालेकुम। ठीक ठाक, शुक्र अल्लाह का।
ओके ओके वेल।
अस्सलाम वालेकुम सर। मैं डॉक्टर शगुफ्ता नईम एबटाबाद से।
डॉक्टर शगुफ्ता कैसी हैं? हाउ इज एबटाबाद?
अल्हम्दुलिल्लाह, आज तो शुक्र है, अच्छा है कि बारिश काफी हुई है इधर।
Okay, Dr. Steven is do not know the Urdu. You talk in English
ओके, दैट्स फाइन।
because this is the time not to start the lecture and just to introduce with Professor Steven.
ओके,
And Professor Steven, Dr. Samina is head of the Department of Pathology in Ahmedabad Medical College.
Great.
And I think जो है सारे इंट्रोडक्शन करा दें। तारा डॉक्टर अरमगाना से शुरू करता हूँ। जी जी।
Assalamu alaikum. Sir, my name is Dr. Armagana Kamar. I'm working as an assistant professor, histopathology section, Pakistan Institute of Medical Sciences, PIMS, Islamabad.
ओके देन कंटिन्यू रखें। डॉक्टर मोहम्मद, डॉक्टर फरवा आप करें ज़रा इंट्रोडक्शन अपना। जी आई थिंक के 2-3 मिनट इंट्रोडक्शन के बाद इंशाल्लाह लेक्चर स्टार्ट करते हैं। बेटा लेक्चर अपना आगे इंट्रोडक्शन कराएं, अपना सारे सारे लोग कराएं।
I'm Dr. Farwa Batul. I'm Secretary, Pakistan Association of Pathologists. I work with Professor Mulazim Hussain Bukhari. And in the coming International PAP conference, I will serve as a Secretary for Pakistan Association of Pathologists.
डॉक्टर समीना आप?
I'm Dr. Shagufta Naeem and I'm working in Ayub Medical College, Ahmedabad as a professor of histopathology, and I used to listen to the lectures of the Cleveland Clinic when they were with the Austrian American Foundation.
Oh, great.
ओके शैला जलील, प्रोफेसर शैला जलील। जी जी बेटा तारुफ करें, फिर जल्दी काम अगला शुरू करते हैं इंशाल्लाह।
जी अस्सलाम वालेकुम।
वालेकुम अस्सलाम।
जी अस्सलाम वालेकुम। आई एम डॉक्टर शैला। आई एम एसोसिएट प्रोफेसर एट शेख ज़ायद हॉस्पिटल, लाहौर, हिस्टोपैथोलॉजिस्ट, and sir is my mentor, Dr. Mulazim Hussain, and I am very grateful for him to let me join this webinar.
यू
Thank
आर
you.
वेरी कॉम्पिटेंट हिस्टोपैथोलॉजिस्ट डॉक्टर शैला। डॉक्टर तारिक, डॉक्टर माहम, सारे इंट्रोडक्शन करें, मैं आपके बस आगे चलते हैं इंशाल्लाह।
Assalamu alaikum, sir. I am Dr. Tariq PGR, Mayo Hospital, Lahore.
Dr. Steven, Mayo Hospital is my mother hospital. My mother college, King Edward, where we are keeping your अपना workshop इंशाल्लाह।
अस्सलाम वालेकुम सर।
डॉक्टर जहदा आप आ गई हैं?
जी सर।
ओके डॉक्टर जहदा अपना तारुफ कराएं, फिर मैं आगे शुरू करूँ लेक्चर।
प्रोफेसर डॉक्टर जायदा रानी, प्रोफेसर ऑफ डर्मेटोलॉजी एट किंग एडवर्ड मेडिकल यूनिवर्सिटी। थैंक्स टू प्रोफेसर मुलाजिम हुसैन, वी आर लर्निंग
नेक्स्ट प्रोफेसर स्टीवन।
Thanks to Dr. Steven as well, Steven
And
Billings.
Dr. Steven, she is your host in KE in my hospital.
Okay, looking forward to meeting you.
Okay. Auzu billahi minash shaitanir rajim. Bismillahir rahmanir rahim. With the name of Allah and with the Darood Salam of Holy Prophet Hazrat Muhammad sallallahu alaihi wasallam. I welcome Professor Steven, and Dr. Steven is a well-known professor of histopathology. He is not only the fellowship, and he is fellowship, so many fellowships and so many things. I do not have the words to count his credibility, the other things. And thank you very much, sir, on the platform of United States Canadian Association of Pathologists. As a president, you welcomed us, and inshallah, we are waiting for your arrival in Pakistan, and hopefully that we have started different lectures, especially dermatopathology, missing in Pakistan especially. Because now I am retired, I am not working in King Medical University, where we started this dermatopathology. Thankful to you, and over to you to start today's first session. Over to Professor Steven.
Okay, well, thank you very much. Thank you for the invitation. And this will be the first of a three-part lectures, sort of as a general overview on inflammatory dermatopathology, mostly geared for, the general surgical pathologist, but, I think, I don't know if in Pakistan, if dermatologists sign out dermatopathology or not, or if only pathologists do. But let's go ahead and get started. You can all see the screen, I hope.
Yes.
So inflammatory dermatopathology, I think a lot of general surgical pathologists find it very difficult. I think in part because there are a lot of overlapping histologic features, and also sometimes the terminology can be kind of confusing if you're not used to it. And most general surgical pathologists that I know really hate inflammatory dermatopathology. They really find it difficult and challenging, and they don't like it. I think one of the reasons they don't like it is it's hard to come up with a specific diagnosis often. And what is really important is try to put it into a reaction pattern if you can, and then you might be able to get to a specific diagnosis. And another thing that is very important is to communicate with the clinicians, the dermatologists or clinicians who are doing the biopsy. And I often tell my trainees that my telephone is my second most important tool after my microscope, because it's important to talk to your clinicians who are doing the biopsies. Well, how do we make a good dermatopathology pathology report? Well, although it seems trivial, you need to know if you're dealing with a tumor or a rash, and sometimes you don't always have that information. And the main thing is you want to put it into one of the basic inflammatory reaction patterns, and we're going to go through some of those today. And then any knowledge of the clinical presentation can be very helpful because that can influence your histologic interpretation. We'll talk about that a little bit. And again, can't emphasize enough communication with your clinicians. All right, so critical to interpreting inflammatory dermatopathology is to recognize different patterns of reaction. The skin has a very limited way of the way it reacts to inflammatory problems, and then if you can identify the predominant pattern, it will help you define diagnostic categories. Now, unfortunately, it's still difficult because you can get overlapping histologic features between different patterns, and we'll talk about that a little bit. And also some entities, some specific diagnostic entities have a variety of different patterns, so that can also make it more difficult. All right, in terms of general concepts, I sort of start with breaking it down into whether or not it is a predominantly epidermal pattern or predominantly dermal pattern or a different type of pattern. If there is significant epidermal change, you want to put it in the diagnosis into one of the epidermal reaction patterns. And then after that, I look at the distribution of the inflammatory infiltrate. Is it predominantly in the superficial dermis, or is it both in the superficial and deep dermis? Is it mostly around vessels? Is it just in the interstitium? Is it nodular, etc.? And then you want to look at the nature of the inflammatory infiltrate. Are they mostly mononuclear cells or lymphocytes and histiocytes, maybe some plasma cells? Or is it mixed? You have lymphocytes and granulocytes like eosinophils or neutrophils. Or is it predominantly granulocytic like neutrophils and eosinophils? And then again, correlation with the clinical presentation as much as possible. All right, in terms of the patterns in which the epidermal patterns include the spongiotic pattern in which you have epidermal spongiosis, the psoriasiform pattern, which you have epidermal hyperplasia, usually without much spongiosis, although you can get significant psoriasiform change in later stages of spongiotic dermatitis. And then interface pattern. In interface pattern, you have damage to the basal layer of the epidermis with dyskeratotic or dead keratinocytes. And then I subdivide the interface pattern into whether or not it is a lichenoid pattern of inflammation or a perivascular pattern of inflammation. And we'll try to get through the epidermal patterns today. In terms of the predominantly dermal patterns, you have superficial perivascular or superficial and deep perivascular. You can see an interstitial pattern in which you can see sort of nodular and diffuse inflammatory infiltrate or palisading granulomas. There's a sclerosing pattern, and then we have sort of other miscellaneous patterns like paniculitis, bullous disease, and a few other things that we'll get towards the end of the lecture series. So this is just a cartoon of spongiotic dermatitis. So spongiotic dermatitis, you have an accumulation of edema fluid within the epidermis that causes the keratinocytes to pull apart. And so they get sort of separated and you can sort of see the desmosomal attachments. And often you have some lymphocytes or inflammatory cells going up into the epidermis. And usually in the spongiotic pattern, you also have a superficial perivascular inflammatory infiltrate. So spongiotic dermatitis can be artificially divided into 3 phases: the acute phase, the subacute phase, and the chronic phase. They have different but overlapping histologic features because they exist along a continuum. In the very early stages of spongiotic dermatitis, the acute spongiotic dermatitis, you have a normal basket weave stratum corneum. In other words, the stratum corneum still looks normal, hasn't had a chance to react to the process. You have pale keratinocytes, and you have spongiosis. And then if the spongiosis is severe, you can get spongiotic vesicles. That's not always present. You'll often have some papillary dermal edema, and then you usually have a superficial perivascular infiltrate of lymphocytes, often, though not always, with eosinophils. So here would be an example of the earliest spongiotic dermatitis you can imagine. You can see the accumulation of the edema fluid between the keratinocytes here, and then a very mild perivascular infiltrate. This is a really advanced or prominent case of spongiotic dermatitis in which you have spongiotic microvesicle formation. You can see the spongiosis, the accumulation of the edema fluid, and then sometimes you get so much fluid up in the epidermis that the desmosomes break apart and it causes little intraepidermal blisters. Notice the normal stratum corneum. This is a very acute phase of spongiotic dermatitis. And then in the dermis, you have a perivascular infiltrate. As you move into the subacute phase of spongiotic dermatitis, the epidermis will start to react to the inflammatory process. And so you will get parakeratosis. You'll often have a diminished granular layer. You'll still have spongiosis, and now you're getting epidermal hyperplasia or acanthosis. And in this sense, it has some overlap with the psoriasiform pattern. And then you have the same perivascular infiltrate of lymphocytes, often, though not always, with the eosinophils, and you tend to have less edema in the papillary dermis. So here's an example of the subacute phase of spongiotic dermatitis. You see the parakeratosis. You see the diminished granular layer. The epidermis is a bit hyperplastic or acanthotic. You can still see some spongiosis and then that perivascular infiltrate. Now, if the process persists, it can develop into chronic spongiotic dermatitis, in which you then will have hyperkeratosis, variable parakeratosis, and now often a more irregular or even thickened granular layer. And you will still get acanthosis or epidermal hyperplasia, again, overlapping with the psoriasiform pattern. And now, once you get into the chronic phase of spongiotic dermatitis, quite honestly, very minimal to only mild spongiosis. You'll have a variable perivascular infiltrate, and the dermis might even become a little fibrotic. So here would be an example of chronic spongiatic dermatitis. Compact hyperkeratosis, a very little bit of parakeratosis, and now a somewhat thickened granular layer, and really only minimal spongiosis within the epidermis, and that same perivascular infiltrate. Now, the common clinical types of spongiatic dermatitis can all be sort of put into the family of eczematous dermatitis, which includes atopic dermatitis, contact dermatitis, nummular dermatitis, dyshydrotic dermatitis or hand-foot dermatitis or pomphilox, or even eczematous drug eruptions. And we're going to talk about these in some detail. So eczema is a clinical term. Histologically, they all look alike. Histologically, they're all essentially a spongiatic dermatitis. And the clinical subtypes are histologically indistinguishable. So you can't really get to a specific histologic diagnosis without really good clinical information. Atopic dermatitis is a chronic pruritic relapsing papular dermatitis. It's associated with history of asthma or allergic rhinitis, has a predilection for the flexural areas, especially in children, and it tends to run in families. So you can see this infant has some atopic dermatitis, but the mom also has atopic dermatitis where they've been really scratching in the same location. You have these accentuation of the skin line secondary to excoriation. Allergic contact dermatitis is also very, very common. You will get erythematous papules, plaques, sometimes vesicles. Sometimes it can have a linear pattern, especially if it's from like the edge of a plant. I don't know what plants cause allergic contact dermatitis in Pakistan, but in the United States we have poison ivy, and that often causes allergic contact dermatitis. This patient here, you can see right beneath the umbilicus, they have this circular pattern, and this patient had a nickel allergy. So they were reacting to the closure of their pants, and they developed a contact dermatitis to that. Microscopically, it looks like a typical spongiatic dermatitis. There is one clue to the diagnosis of allergic contact dermatitis, is if you have collections of Langerhans cells in the epidermis. That is a clue. It's not entirely specific or not entirely sensitive, but it is a clue to the diagnosis of allergic contact dermatitis. So here is a biopsy from a case of allergic contact dermatitis. It looks like a subacute spongiatic dermatitis. We have parakeratosis, plenty of spongiosis, and then here we have these collections of Langerhans cells within the epidermis. Now these reniform nuclei with a fair amount of cytoplasm. These are Langerhans cell collections in the epidermis. It's a higher power picture showing these Langerhans cells. Now, Langerhans cells, we did this study a number of years ago. Langerhans cells are associated with positive patch tests in patients. It's not tremendously sensitive, but it's relatively specific for the possibility of patch test positive allergic contact dermatitis. And importantly, eosinophils really are not statistically associated with allergic contact dermatitis. You can see eosinophils in any type of spongiatic or eczematous dermatitis, and it doesn't correlate with patch test positive patients. Another type, this is one of the most common things I get consulted on with my gynecologic pathology colleagues, is biopsies of spongiatic dermatitis involving the vulva, and allergic contact dermatitis and contact dermatitis are the most common forms of spongiatic dermatitis in vulvar skin. So this would be a spongiatic dermatitis and happens to be a vulvar biopsy. Very common in that clinical setting. Nummular dermatitis is another very common form of eczematous dermatitis that is biopsied. Patients present with these round to oval patches and plaques, often on the extremities. Microscopically, it's a spongiatic dermatitis, but there's usually significant epidermal hyperplasia, so it has overlap with the psoriasiform dermatitis pattern. The differential diagnosis, both clinically and histologically, can be psoriasis, and we'll talk about that in a little bit more detail. So here is a clinical example of nummular dermatitis. You can see these patches and plaques on the extremities. And microscopically here, it just looks like a subacute spongiotic dermatitis. Dyshidrotic eczema or Pomphlox or hand-foot dermatitis, you typically have symmetric involvement of the hands and or feet, often has a vesicular appearance like you can see here. And because of that, the clinical differential diagnosis is often, especially on the feet, a dermatophyte infection. But microscopically, it just looks like a spongiotic dermatitis. Eczematous drug reactions, they account for 5 to 10% of drug reactions are eczematous in nature. Now, eczematous drug reactions tend to be more widespread, sort of involving a greater body surface area. They tend to be more common in older patients, mostly because older patients are more likely to be on a variety of different medications compared to younger patients. Microscopically, again, it just looks like a spongiotic dermatitis. You cannot tell them apart microscopically. So practical tips for eczematous dermatitis or spongiotic dermatitis. My diagnosis line is usually just spongiotic dermatitis and then with a comment. Now in my comment, I will give a microscopic description of what it looks like. And then I'll just say the histologic features are compatible with an eczematous dermatitis. The differential diagnosis could include atopic dermatitis, nummular dermatitis, allergic contact dermatitis, etc. And clinical pathologic correlation is recommended or essential. Now, if you know good clinical information, then you can say it's consistent with allergic contact dermatitis. If you know the patient has an exposure, they have that you can be more precise about, or if they have a new medication, then you can tailor your comment towards what the clinical information is. It's always important to eliminate more specific entities when possible. If you see neutrophils in the stratum corneum or epidermis, consider excluding a dermatophyte infection. Also consider the possibility of psoriasis. So in that setting, and also always consider PAS or GMS stains in vulvar biopsies. Sometimes the fungal infections are kind of subtle there. If you see Langerhans cell collections or microabscesses in the epidermis, again, it's not specific, but it suggests the possibility of allergic contact dermatitis. And I will put that in my comment, that given the presence of Langerhans cell collections in the epidermis, the possibility of allergic contact dermatitis should be considered. All right, we're going to move on to a different entity, stasis dermatitis. Stasis dermatitis occurs in the lower extremities and is associated with venous insufficiency. So you always see it essentially in the lower leg, below the knee. You never see it in the thigh. Sometimes patients will develop ulcers, and sometimes clinically it can even mimic a neoplasm like squamous cell carcinoma, and I'll show you a paper about that. Microscopically, you tend to see a subacute to chronic spongiotic dermatitis because it's the chronic process. You'll often see some epidermal hyperplasia or acanthosis, and the most important histologic feature is this lobular proliferation of relatively thick-walled blood vessels in the papillary dermis. You'll also often see some extravasated erythrocytes, some hemosiderin-laden macrophages or siderophages, and some perivascular lymphocytes. And if it's a long-standing case, you may see some dermal fibrosis. Clinically, it tends to again occur on the lower legs, often, around the ankle area or the shin area. You can see this sort of eczematous plaque and patches on the lower legs. Here's a case, you can see it looks like a chronic spongiotic dermatitis here. Notice this perivascular inflammatory infiltrate. And if you go to higher power, notice that this lobular proliferation of these relatively thick-walled blood vessels in the superficial dermis. That is very characteristic of stasis dermatitis. Sometimes, though, stasis dermatitis doesn't present as bilateral plaques. It can sometimes even start as a solitary lesion that can mimic a neoplasm like squamous cell carcinoma or basal cell carcinoma. And this is a study we did a number of years ago when we recognized this phenomenon of isolated lesions of stasis dermatitis. Clinically, that might get confused with the neoplasm, but microscopically, it just looks like a stasis dermatitis. You have this chronic spongiotic dermatitis and these relatively thick-walled papillary dermal blood vessels. So the differential diagnosis with stasis dermatitis is with a, eczematous dermatitis, and it's important to know that if you can have an eczematous dermatitis, like an allergic contact dermatitis, on top of or superimposed on a background of stasis dermatitis. You may not always be able to tell them apart. Kaposi sarcoma can sometimes be confused with really severe forms of stasis dermatitis, because in severe forms of stasis dermatitis, you can have a prominent fibroblastic proliferation that can resemble Kaposi sarcoma. In terms of clues or practical tips, keep a high index of suspicion of biopsies from the lower legs that you might be dealing with stasis dermatitis. And remember the vascular features, the lobular proliferation of the thick-walled papillary dermal blood vessels is the most important diagnostic finding. We're going to move on to a different pattern, the psoriasiform pattern. And just remember there's a lot of overlap between the psoriasiform and the spongiotic pattern. In the psoriasiform pattern, you tend to have lots of epidermal hyperplasia without much spongiosis in the epidermis. And then you have typically a perivascular infiltrate. I'm going to mostly talk about psoriasis and lichen simplex chronicus. We'll also touch on dermatophyte infections a little bit as well. Psoriasis, the most common form is psoriasis vulgaris. Usually presents in younger patients, but then there's a second peak in elderly patients in the 6th and 7th decade. You classically get erythematous plaques with silvery scale, involves the extensor surfaces, the scalp, the gluteal cleft, the glans penis, all very common locations. Frequently, the patients may have nail findings. You may get nail pitting and yellow discoloration of the nails. And then a small subset of patients will develop psoriatic arthritis. This is usually in patients who also have severe skin disease. Microscopically, you see very uniform epidermal hyperplasia for psoriasis vulgaris, uniform hyperplasia with elongated reedy ridges. You'll see an absent or at least diminished granular layer. You'll see prominent parakeratosis, but the parakeratosis does not have serum fluid, doesn't have edema fluid within the parakeratotic scale, so it looks histologically like a dry scale, unlike what you see in spongiotic dermatitis. You typically see neutrophils in the stratum corneum. You may also see them in the epidermis. You'll see suprapapillary plate thinning, and I'll show you examples of that. And another very important feature, dilated and tortuous papillary dermal blood vessels. And also, eosinophils are usually not present in conventional psoriasis. I mean, you can see one or two, but if you see lots of eosinophils, it is probably not psoriasis unless it is a drug-induced form of psoriasis. So this is a fairly classic example of psoriasis vulgaris. Notice the confluent, dry parakeratotic scale. Here you see these collections of neutrophils, which look like little black dots in the stratum corneum. Very uniform epidermal hyperplasia. Look how uniform it is. You can draw a straight line around the bottom of the epidermis. Suprapapillary plate thinning, meaning the top of the dermal papillae to the external environment is relatively thin compared to how long the reedy ridges are. Here are the collections of neutrophils in the stratum corneum. Prominent parakeratosis. Here's some neutrophils in the upper epidermis. Notice an absence of the granular layer. Here's a different case of psoriasis vulgaris. This case did not have a really thick stratum corneum or parakeratotic scale, but it is there. Diminished granular layer. And notice the dilated and papillary dermal blood vessels. Notice the very uniform hyperplasia of the epidermis. And again, focal collections of neutrophils up in the stratum corneum and upper epidermis here. There are some variants of psoriasis. Pustular psoriasis tends to be associated with pregnancy or in patients with psoriasis who get a short course of systemic steroids and they get a rebound phenomenon where they get prominent pustular psoriasis. Pustular psoriasis, unlike psoriasis vulgaris, is a more rapid onset process. And because it is a more rapid onset process, you have less prominent epidermal hyperplasia, and the granular layer is often maybe diminished, but it's usually not absent. And in pustular psoriasis, you see these large neutrophilic abscesses in the epidermis and stratum corneum, and oftentimes you'll have a little bit of spongiosis. The differential diagnosis, which I don't really have time to go into today, includes things like candidiasis, acute generalized exanthematous pustulosis, IgA pemphigus, or eczematous dermatitis with secondary impetiginization. Here's an example we had of pustular psoriasis. This patient had widespread epidermal pustules. You can see this large pustule here. Notice the granular layer is still somewhat intact, and it doesn't quite have the uniform epidermal hyperplasia. Another variant of psoriasis, clinical variant, is guttate psoriasis. In guttate psoriasis, it is another type of psoriasis that is characterized clinically by a rapid onset. You have this widespread, small little papules and plaques on the skin, and patients often have an antecedent streptococcal pharyngitis or streptococcal infection that triggers the eruption of guttate psoriasis. Microscopically, you see sort of minimal epidermal hyperplasia or acanthosis. You may or may not see a diminished granular layer. And the most important feature are these focal mounds of parakeratosis with collections of neutrophils on top of them. Sometimes you don't see the neutrophils. Sometimes you just see the mounds of parakeratosis, though. So just be aware of that. So this is guttate psoriasis. You see this mound of parakeratosis with neutrophils overlying a mildly acanthotic and honestly mildly even spongiotic epidermis. The most important differential diagnosis is probably pityriasis rosea, and pityriasis rosea can look a lot like guttate psoriasis, but it doesn't have neutrophils in the mounds of parakeratosis, and you'll usually have a little bit of hemorrhage in the papillary dermis. Practical tips for psoriasis. Eosinophils, just remember, are usually absent in psoriasis unless it's inverse psoriasis or drug-induced psoriasis. The epidermal hyperplasia is not always uniform, especially if they've been partially treated. If you see significant impetiginization, that really argues against psoriasis. Psoriatic skin doesn't usually get secondarily infected by bacteria. And remember, sometimes if patients have had steroids or treatment before they get a biopsy, you may not see all the features of psoriasis. Always consider getting a PAS or GMS stain to exclude a fungal infection. If you're uncertain about the diagnosis, you can say psoriasiform dermatitis as your descriptive diagnosis and say in a comment that it has, some features that could be consistent with psoriasis in the right clinical setting. Just to sort of highlight how partially treated, this is a case of partially treated psoriasis. The patient, was using topical steroids before they went to go see their dermatologist or their physician. And so not all the features are here. It does have relatively uniform hyperplasia, prominent parakeratosis, but notice the granular layer is intact. And I would say in here, one of the clues are these dilated and tortuous papillodermal blood vessels. That's a nice clue to partially treated psoriasis. Let's talk about dermatophyte infection. Dermatophyte infection clinically are usually annular scaly plaques with central clearing, usually on the trunk, but not always. Microscopically, you see neutrophils in the stratum corneum. You will see parakeratosis, and you will see hyphae in the stratum corneum, but usually you need to do a PAS or GMS to see the fungal hyphae. And you'll have variable amounts of epidermal hyperplasia or acanthosis. So here's a classic example of a dermatophyte infection, these annular plaques with scale and central clearing. Microscopically, you see collections of neutrophils, some epidermal hyperplasia and spongiosis, and these are the fungal hyphae highlighted by a PAS stain. So in terms of practical tips, PAS stains are fairly inexpensive, so always consider ruling out a dermatophyte infection when you see neutrophils in the stratum corneum. And the other situation I essentially almost always do a PAS or GMS stain is if you have a history of a patient with a rash that's not responding well to topical steroids. So here's an example. This is a dermatophyte infection. The patient had a rash. They're being treated with topical steroids, but it was persistent. Histologically, this really doesn't look like a dermatophyte infection. I mean, it looks like a mild spongiotic dermatitis. But because of the history of poor response to topical steroids, we did a fungal stain, and here are the fungal hyphae in the stratum corneum. All right, now we're going to move on to lichen simplex chronicus and prurigo nodularis. Clinically, this is essentially the spectrum of the same dermatologic disease. It is a disease that is secondary to persistent rubbing and scratching in a given area. Lichen simplex chronicus presents as plaques, and prurigo nodules present as nodules. And importantly, the lesions are only seen where the skin can be reached. And common places include the posterior scalp, where people will scratch a lot, the ankle, the shin, forearm. Genitalia is actually a relatively common place for lichen simplex chronicus, especially in vulvar biopsies. You can also see lichen simplex chronicus secondarily develop in a patient like persistent eczematous dermatitis, like a persistent contact dermatitis or atopic dermatitis can also have features of lichen simplex chronicus on top of it. At least in the United States, I can't speak to in Pakistan, but genital lichen simplex chronicus is often clinically mistaken by our gynecology colleagues as lichen sclerosus. So you'll have a biopsy and it says rule out lichen sclerosus, and really it's just lichen simplex chronicus. And I'll show you an example of that. So on the left is lichen simplex chronicus, a sort of indurated plaque. And on the right, this patient had numerous prurigo nodules. And the patient on the right actually was suffering from chronic renal failure. So they were very pruritic. And so they were constantly scratching at their skin. You can tell that this patient is right-handed because the lesions are much worse on her left arm than her right arm. Microscopically, you essentially see the same thing in both of these entities. You'll see prominent compact hyperkeratosis. You may or may not see parakeratosis. You tend to see a very thickened granular layer. You will see epidermal hyperplasia or acanthosis, sometimes with a pseudoepitheliomatous pattern. You will see vertical fibrosis of the papillary dermis. This tends to be less prominent in genital skin, though. And then usually you see only a very mild perivascular lymphocytic infiltrate. You may not even see any significant inflammation. So it looks like acral skin because of the compact hyperkeratosis and thick granular layer, but it's not in an acral location. And Bernie Ackerman sort of coined the phrase, it looks like hairy palm sign, he would call it, because it looks like acral skin, but you would have it in hair-bearing areas. So here's an example of a prurigo nodule. You can see compact hyperkeratosis, a very thickened granular layer, lots of epidermal hyperplasia. Yes, there's a little bit of parakeratosis here too. And there's some papillary dermal fibrosis. And yes, there's a little bit of inflammation, but not that much inflammation considering how much epidermal change there is. Here's a case of a prurigo nodule with pseudoepitheliomatous hyperplasia. So it somewhat resembles squamous cell carcinoma, but there's really no cytologic atypia and no desmoplastic stromal response. Now, we did, this is a case of lichen simplex chronicus. This is a picture from an article occurring on the vulva. You can see these white sort of plaques on the vulvar skin and areas of excoriation. We looked at our experience with this in vulvar biopsies, and we found, our GynPath people would tend to call it non-specific chronic dermatitis, and we could more accurately diagnose as 26 cases of lichen simplex chronicus over a 5-year period of patients, and when their diagnosis was not assigned to a specific reaction pattern. So here's a case of vulvar lichen simplex chronicus. Notice how thick the epidermis is. Notice how thick stratum corneum, a bit thickened granular layer. Here's a higher power picture. The papillary dermal fibrosis is still there, but not as prominent. Notice not much inflammation, but very thick stratum corneum. This is very specific. You can make a very specific diagnosis of lichen simplex chronicus if you see this. Now, I would recommend ruling out a fungal infection in a vulvar biopsy, but absent any fungal organisms, you can make a very specific diagnosis of lichen simplex chronicus. Differential diagnosis can include partially treated psoriasis. On vulvar skin, you might wonder about lichen sclerosus, which in early phases of lichen sclerosus, you can see some psoriasiform hyperplasia, and I'll talk about that in a little bit. verruca or condylomas, but they usually don't really have true coilocytes, and clinically it's a bit different. Chronic spongiatic dermatitis, and of course, chronic spongiatic dermatitis can coexist with lichen simplex chronicus. And if you have pseudoepitheliomatous epidermal hyperplasia, you might confuse it with squamous cell carcinoma, but there really is no atypia, and there's no desmoplastic stromal response. So practical tips for lichen simplex chronicus and prurigo nodule. It looks like acral skin in a non-acral location, the so-called hairy palm sign. Clinical history, is it pruritic? If you're not certain, you can give a descriptive diagnosis of psoriasiform dermatitis and say it has features of lichen simplex chronicus or prurigo nodule. It may be sometimes superimposed on a spongiatic dermatitis, like a chronic atopic dermatitis. So if you have a lot of inflammation in the dermis, then you might say like chronic spongiatic dermatitis with superimposed features of lichen simplex chronicus as your diagnosis. It's a fairly common finding in vulvar biopsies, just remember that. And if you can give a precise diagnosis of lichen simplex chronicus, that will help out your clinician in trying to manage the patient. Okay, now we're going to switch to interface pattern. And this will be the last section for the lecture today, and then we'll come up with another time for the next two parts of the lecture series. And interface pattern is defined by two things. You get basal vacuolization of dermal epidermal junction and dyskeratotic or necrotic or dead keratinocytes along the dermal epidermal junction. And then you can subdivide it into what type of inflammatory reaction pattern is associated with it. Lichenoid or perivascular. And lichenoid includes things like lichen planus, lichenoid drug eruption, early lichen sclerosis, and then perivascular, we're going to talk about these entities as well, like toxic epidermal necrolysis, connective tissue disease, etc. So this is just a cartoon of a lichenoid interface dermatitis. You can see a lichenoid lymphocytic infiltrate. These clear bubbles represent your basal vacuolization, and these black circles are just the dyskeratotic keratinocytes. So we'll start with the prototypical lichenoid interface dermatitis, lichen planus. In lichen planus, you see pruritic, violaceous polygonal papules, usually on flexural surfaces of the wrists and ankles, but sometimes it is widespread. Lichen planus, you see hyperkeratosis without parakeratosis. You'll see epidermal hyperplasia or acanthosis. You'll often see wedge-shaped hypergranulosis. You'll see interface change with a dense band-like lymphocytic infiltrate. The basal layer often looks more pink or more squamatized, and the reedy ridges or the reedy pegs take on a more jagged or sawtooth-like appearance, and you'll also see scattered dyskeratotic keratinocytes along the dermo-epidermal junction. So here's an example of lichen planus, compact hyperkeratosis. You can see this sort of wedge-shaped hypergranulosis in areas, this dense lichenoid lymphocytic infiltrate, and notice how the reedy ridges, instead of being nice and rounded, are sort of jagged and pointed or sawtooth-like. Higher power picture, you can see the lichenoid lymphocytic infiltrate. You see basal vacuolization along the dermo-epidermal junction, and these pink globules here are dyskeratotic or dead keratinocytes. Notice the wedge-shaped hypergranulosis and the compact hyperkeratosis. Just a higher power picture showing you the interface change with numerous dyskeratotic keratinocytes that tend to be concentrated at the dermo-epidermal junction or in the very lower part of the epidermis. And again, this lichenoid lymphocytic infiltrate, and there you have some basal vacuolization or for interface change along the dermo-epidermal junction. This is a case of hypertrophic lichen planus. Sometimes you get pseudoepitheliomatous hyperplasia. In my experience, hypertrophic lichen planus is usually on the legs. But notice you still have that prominent hyperkeratosis, still the wedge-shaped hypergranulosis, and the lichenoid lymphocytic infiltrate. And here we can see again the lichenoid lymphocytic infiltrate, some basal vacuolization, maybe a dyskeratotic keratinocyte there, maybe one that's starting to die there. And it can sometimes be difficult to distinguish hypertrophic lichen planus from squamous cell carcinoma. And There are some features that can help you with that. For example, if you see perforating elastic fibers going up through the epidermis, that's much more likely to be associated with squamous cell carcinoma. If you see significant parakeratosis, it's much more likely to be associated with squamous cell carcinoma, as is significant solar elastosis. If you see if you see psoriasiform hyperplasia, it's more common in hypertrophic lichen planus. If you see really compact hyperkeratosis, more common in hypertrophic lichen planus. Or if you see wedge-shaped hypergranulosis, more common in hypertrophic lichen planus. Lichen planus, of course, is not just a cutaneous disease. It's fairly common to involve the oral mucosa. And sometimes that's the sole manifestation in between 15 to 35% of patients. Usually it involves the buccal mucosa, and you get these sort of reticulated white plaques involving the buccal mucosa. And the biopsy, you'll see a lichenoid lymphocytic infiltrate, but because it's involving mucosa, not the epidermis, you don't see prominent hypergranulosis, you don't see prominent compact hyperkeratosis, and you'll often see a little bit of parakeratosis. You can also see lichen planus involving the esophagus. This is likely under-recognized. At least in our country, it's usually more common in middle-aged Caucasian or white females. Symptoms include dysphagia and odynophagia. Most patients also have coexisting oral disease, but not always, and esophageal lichen planus can be the presenting symptom in up to 18% of patients. It can also be seen as a late onset manifestation of lichen planus. This is what it might look like endoscopically. I'm not a gastroenterologist, so I'm not going to comment on this too much, but you can see these sort of erythematous areas and white sort of plaque-like areas in the esophagus. Now, you never get a well-oriented biopsy from esophageal endoscopy, but what you see is we can see the squamous epithelium here, and notice the numerous dyskeratotic epithelial cells in this dense lymphocytic infiltrate. That's very suggestive of esophageal lichen planus. Now, lichen sclerosis, early lichen sclerosis is actually an interface dermatitis, and it's often misspelled, or misdiagnosed rather. Early lichen sclerosis, you will see hyperkeratosis and hypergranulosis. You'll see psoriasiform hyperplasia. You'll see lymphocyte exocytosis. You may see some spongiosis. You'll see interface change, so basal vacuolization. But you tend to see dyskeratotic keratinocytes, not just concentrated along the dermal-epidermal junction, but you'll see them up throughout the entire thickness of the epidermis. Another feature that's often but not always present is the thickened basement membrane and sclerosis of the tips of the dermal papillae and collagen cuffs around blood vessels. Here's a case of very early lichen sclerosis. You see compact hyperkeratosis, a bit of a thickened granular layer. Notice it has somewhat psoriasiform hyperplasia. Notice you'll see some basal vacuolization, but look, this keratotic keratinocyte here and here and here, higher than what you would expect to see in lichen planus. And notice there's some very subtle early fibrosis of the papillary dermis. Here's another case of early lichen sclerosis. You can see exocytosis of the lymphocytes, dyskeratosis fairly high up. And here I think you can make out a slightly thickened basement membrane along the dermal-epidermal junction. And there's this really nice paper from Phil Lebois and Maxwell Fung a number of years ago, published in American Journal of Surgical Pathology, about how to distinguish early lichen sclerosis from lichen planus affecting vulvar skin. So if you see psoriasiform hyperplasia with a lichenoid infiltrate, very common in early lichen sclerosis, uncommon in lichen planus. Epidermotropism, or significant exocytosis of lymphocytes into the overlying epidermis. It's a feature of early lichen sclerosis, but not of lichen planus. Decreased elastic fibers. If you do an elastic stain, you find that in early lichen sclerosis, but not so much and not very commonly in lichen planus. Basement membrane thickening. It's a feature of early lichen sclerosis, but not of early lichen planus. In contrast, if you see basal squamatization, you see that, and that's a feature more common in lichen planus. Wedge-shaped hypergranulosis, more common in lichen planus. And many cytoid bodies, in other words, dyskeratotic keratinocytes in the upper part of the dermis, much more common in lichen planus. If you have pointed reedy ridges, much more common in lichen planus. So if you sort of keep these features in mind, you can distinguish, generally speaking, early lichen sclerosus from early lichen planus. Moving on to lichenoid drug eruptions. These tend to be more widespread. Violaceous papules can occur anywhere from weeks to months after a new medication, can progress to an exfoliative dermatitis. And microscopically, it can be indistinguishable from lichen planus, but if you do see parakeratosis and numerous eosinophils, it favors a lichenoid drug eruption. You can sometimes see a few eosinophils in lichen planus. Usually it's the hypertrophic form of lichen planus, but most cases of lichen planus don't have eosinophils, or if eosinophils are present, they are rare. So if you see numerous eosinophils, it favors a lichenoid drug eruption. And again, clinical correlation is essential. Lichen planus usually isn't widespread like in lichenoid drug eruption. Fixed drug eruption is characterized by one or more erythematous to violaceous to brown plaques that usually are restricted to a given area of the body. Rare forms are generalized, just so you know. Tends to be on the extremities and genitalia. Usually develops within hours after taking the medication. And the most common medication triggers include non-steroidal anti-inflammatory drugs, sulfa drugs, barbiturates, etc. Patients often develop burning pain and vesiculation at the site. And they call it a fixed drug eruption because if they take the medicine again, it will recur in the same location on re-challenge. And when they take the medicine again, they'll get the same type of reaction in the same location. So clinically, again, you can see these plaques sort of regionally develop in a given body area. They can be erythematous to brown like this one. They tend to be browner in more pigmented skin. Microscopically, you see marked interface change. You'll see lymphocytes tagging the basal layer, sometimes with a more lichenoid pattern, variable number of neutrophils and eosinophils, and a key feature, you get frequent melanophages or melanin-containing melanin-containing macrophages. Sometimes it can progress to a bullous eruption, and I'll show you a picture. So here is a fixed drug eruption, somewhat lichenoid infiltrate, known as the prominent basal vacuolization. Here, a different case, prominent basal vacuolization, and in the circle you can see melanophages and some eosinophils. This is a severe case that progressed to a bullous fixed drug eruption. We can see necrosis of the epidermis. But there's still some melanophages down here, and as well as a few eosinophils. Another lichenoid disease is pityriasis lichenoides et varioliformis acuta, or PLEVA. In this disease, you get recurrent crops of flesh-colored to erythematous papules. The lesions can involve into vesicles with hemorrhagic lesions and crusted ulcerations, and they will leave behind varioliformis-like scars. Now, there's also a chronic form of this that tends not to be scarring, pityriasis lichenoides chronica. Microscopically, you see early on, you'll see scale cross with interface change, often with a lichenoid lymphocytic infiltrate, dyskeratosis and exocytosis of lymphocytes. If you get a biopsy of a really early lesion, you may not see the epidermal changes. And if you get a biopsy of a late lesion, you may see epidermal ulceration. So in the typical biopsy, you'll see a lichenoid and wedge-shaped dermal lymphocytic infiltrate of small lymphocytes with occasional neutrophils, and then often with some dermal hemorrhage. Here's a case of PLEVA. Again, you can see the cross scale, this lichenoid infiltrate with hemorrhage. Notice the infiltrate isn't just lichenoid, though. It does go deeper into the dermis. And here you can see, again, the interface change and somewhat lichenoid and perivascular infiltrate with prominent hemorrhage that we see in higher power here. Just again to show you the parakeratotic scale and prominent exocytosis of lymphocytes and lots of hemorrhage. Sometimes the lymphocytes can look a little bit atypical, and some of them can be CD30 positive. Not to be confused with lymphomatoid papulosis, though. All right, now I'm going to talk about interface dermatitis with a predominantly perivascular pattern of infiltrate, in which the infiltrate can be either superficial or superficial and deep perivascular. We'll start with erythema multiforme. This is a clinical spectrum. Erythema multiforme is classically associated with herpes simplex infections, can also be associated with mycoplasma infections or medications. Tends to be a self-limiting episodic eruption, in which you get these erythematous macules, papules, or the classic targetoid lesion with that central area of necrosis. And then there's Stevens-Johnson syndrome. This is usually triggered by drugs or infection. Typically antibiotics or anticonvulsants. Usually occurs within days to a few weeks after starting a new medication. You will get mucous membrane involvement, but less than 10% of the total body surface area is involved. And at the other end of the spectrum is toxic epidermal necrolysis, in which you get widespread tender macular erythematous eruption with large blisters involving more than 30% of the body surface area. And then there's this sort of overlap category of Stevens-Johnson syndrome, toxic epidermal necrolysis overlap, in which you have more than 10, but and up to 30% of the body surface area involvement. So sort of in between clinically Stevens-Johnson syndrome and toxic epidermal necrolysis. This is a really medically serious condition. Patients, up to 25 to 50% of patients will die of this disease. Microscopically, though, erythema multiforme, Stevens-Johnson syndrome, and toxic epidermal necrolysis essentially all look the same. It is an acute onset process. And so because it is an acute onset process, you tend to have a normal vascular stratum corneum, and you have lots of interface change, basal vacuolization, and numerous diskeratotic keratinocytes, but usually only a very mild superficial perivascular lymphocytic infiltrate. So lots of epidermal damage, but not much inflammation. Here's a different case, two different cases. You can see lots of diskeratotic keratinocytes, basal vacuolization, and some perivascular infiltrate. And this happens to be a case from toxic epidermal necrolysis, in which there was full thickness epidermal necrosis. And again, though, not much inflammation. One thing that clinically toxic epidermal necrolysis can be confused with is staph scalded skin syndrome. But staph scalded skin syndrome is caused by a toxin elaborated by a bacteria that causes a split in the epidermis. So you will see a loss of the granular layer and loss of the stratum corneum. You're not seeing interface change with dyskeratosis. If you have a little bit of the stratum corneum intact, you may see a few neutrophils up here, but no interface change. So practical tips for erythema multiforme, Stevens-Johnson syndrome, and toxic epidermal necrolysis. You'll see dyskeratotic or necrotic keratinocytes, but a normal stratum corneum, and a mild perivascular infiltrate, certainly more mild compared to how much epidermal damage there is. And histologically, you cannot tell erythema multiforme, Stevens-Johnson syndrome, and toxic epidermal necrolysis apart. That you rely on the clinician for putting in the right clinical diagnosis. All right, moving on to infiltrates with superficial and deep infiltrate. Lupus erythematosus. So you have three different types of lupus erythematosus. You have chronic or discoid lupus, in which you have these well-demarcated scaly plaques that can be hyper or hypopigmented, usually on the head and neck or other sun-exposed skin. Most patients with chronic or discoid lupus only have cutaneous disease. Subacute lupus is clinically associated with annular plaques on the upper trunk and extensor surfaces of the arms, most classically. And then acute lupus associated with systemic lupus erythematosus. Patients get this erythematous or malar rash and with positive serologies. Here's an example of discoid lupus. You can see these hyper and hypopigmented plaques on the face. Subacute lupus, this nice annular plaque. And then that classic butterfly or malar rash in acute lupus. Histologically, there's a lot of overlap between lupus erythematosus subtypes, and I don't really try to subdivide them histologically that much, but you will get interface change with basal vacuolization, and you tend to have a perivascular and periadnexal, predominantly lymphocytic infiltrate. You may have epidermal atrophy, and you classically have increased dermal mucin. The differential diagnosis mainly centers on dermatomyositis more so than these other entities. Here's a very classic case of lupus erythematosus. There's interface change along the dermal-epidermal junction, and then a superficial and deep perivascular and periadnexal or perifollicular lymphocytic infiltrate. You can see the interface change affecting the follicle. You can see basal vacuolization and dyskeratotic keratinocytes in the follicle surrounded by a lymphocytic infiltrate. Here you can see the interface change in the epidermis, the basal vacuolization, lymphocytes sort of attacking the epidermis. Notice this is a chronic phenomenon, so you tend to have hyperkeratosis. Sometimes you'll get marked epidermal atrophy, and notice the dyskeratosis here, and notice the numerous melanophages. That sort of implies sort of a chronic process when you get lots of melanophages. And this is what dermal mucin looks like under an H&E stain. You can see this dot-like or stringy sort of subtle blue-gray material between the collagen bundles of the reticular dermis. Here's another case of lupus erythematosus. You can see a little bit of focal interface change here, mostly around the follicles, but a superficial and deep perivascular infiltrate. You can see some interface change along the follicle. Here's sort of a late stage case of lupus erythematosus in which you don't have a lot of active inflammation, but you have a markedly thickened basement membrane. And some follicular plugging. Here's a case of lupus erythematosus with pseudoepitheliomatous hyperplasia. That's not very common, but it can happen. You see prominent interface change, and again, perivascular, periadnexal lymphocytic infiltrate. Probably the big differential diagnosis with lupus is dermatomyositis. Dermatomyositis is a systemic disease associated with muscle weakness, but some patients do not have muscle weakness and they only have cutaneous dermatomyositis. Patients classically have this violaceous periorbital discoloration or rash and a violaceous rash on the face and neck. They'll get periungual erythema and Gotrin's papules on the hands. So this patient has a heliotrope rash involving the eyelids, and you can see Gotrin's papules and periungual erythema. Microscopically, dermatomyositis is also characterized by basal vacuolization, but instead of having a superficial and deep infiltrate, you really only have a superficial infiltrate, and it's often very mild. You typically do see increased dermal mucin, and the differential diagnosis could include lupus or graft versus host disease. So here's a case of dermatomyositis, some dyskeratosis, some basal vacuolization, and notice how mild the inflammatory infiltrate is. You can still appreciate dermal mucin. See that blue-gray material between the collagen bundles here. That's dermal mucin. Now we see here again, increased dermal mucin, but not much inflammation. And sometimes in a given biopsy, you're not going to see any active disease. You may need multiple biopsies before you can find the interface change. So practical tips for lupus and dermatomyositis. You almost never see eosinophils in lupus or dermatomyositis. Increased mucin is a helpful feature, but it's not terribly specific. There is a form of lupus that we'll talk about a different day, tumid lupus, which lacks interface change. So lupus can have a superficial and deep pattern, but dermatomyositis typically has a superficial perivascular infiltrate. Sometimes you'll see some reactive atypia in lupus erythematosus that looks a little bit like actinic keratosis. Dermatomyositis typically has a milder infiltrate. And if you're uncertain, if you don't have good clinical information and you can't make up your mind, you can give a descriptive diagnosis of interface dermatitis and say that your differential diagnosis would include connective tissue disease, such as lupus erythematosus or dermatomyositis. All right, I'm going to finish very briefly with graft versus host disease. Clinically, graft versus host disease is divided into acute and chronic forms. Usually, the earliest you will see acute graft versus host disease is somewhere between 2 to 4 weeks after stem cell transplant. Rarely see it in solid organ transplants. You classically see a macular erythema on the trunk, hands, neck, hands, and feet. Sometimes in severe cases will form blisters. Patients will often have systemic symptoms like diarrhea. They may also have like elevated liver function tests. Chronic graft versus host disease tend to develop months to years later. And classically, you will see either a lichenoid or sclerodermoid form. And I'll show you brief examples of those. So this is a case of acute graft-versus-host disease. And again, this is sort of summarize the clinical findings of acute versus chronic GVHD. There is a 4-tiered grading system for acute graft-versus-host disease, and grade 0 kind of doesn't make any sense because they call it normal epidermis. In grade 1 GVHD, you'll see basal vacuolization and a mild perivascular infiltrate. In grade 2, you'll see basal vacuolization, but you'll start to see dyskeratotic keratinocytes. In grade 3, you'll see basal vacuolization, dyskeratotic keratinocytes, and cleft formation. In grade 4, you'll see complete separation of the epidermis from the dermis. I essentially almost never make a diagnosis of grade 1 graft-versus-host disease. I want to at least see some dyskeratosis before I'm comfortable making that diagnosis. Here's an example of grade 2 graft-versus-host disease on the left. You'll see basal vacuolization with some dyskeratosis. And this is grade 3, where you're starting to see cleft formation start between the epidermis and dermis. Sometimes you will see the interface change around follicles, so just make sure you look at the follicles too. This is dyskeratosis here and some interface change around the follicles. In lichenoid graft-versus-host disease, it looks a little bit like a lichen planus. You have this wedge-shaped hypergranulosis, compact hyperkeratosis, some interface change. In this case, the infiltrate is pretty mild. Sometimes it can be more prominently lichenoid. And in sclerodermoid graft-versus-host disease, you'll see dermal sclerosis, which we'll talk about in another lecture in terms of like scleroderma and morphia. But it looks like morphia or scleroderma, but in the setting of stem cell transplant. All right, that's the end of part 1. And I think there were some questions in the chat.
Thank you so much, Professor Steven. One of the questions, very important questions, is by Dr. Can you ask Dr. Samina to yourself how differentiate stasis dermatitis from the vascular neoplasm and angioendothelioma? One question.
Hang on. All right. Clearly, when stasis dermatitis looks different from a vascular neoplasm because the vessels have a normal anatomic distribution. You know, they don't look like they're forming a tumoral mass. You see this, and the vessels tend to be in their normal locations, just relatively thick, but in a normal anatomic location. Here's another question.
Question from Anita. Professor Anita is from India, our colleague.
Okay.
And I'm very lucky that in this session, where Indian and Pakistani both are sitting. The question is the role of exfoliative cytology in the cheek mucosa to distinguish lichen planus and an early squamous cell carcinoma. What is your
I have to admit, I have absolutely no experience in that because I don't do cytopathology.
Yes.
So I would assume that if you see significant cytologic atypia, that would be helpful, but I am not a cytopathologist, so I can't actually answer that question with any confidence. I apologize.
I think, Dr. Steven, in my experience, I do not think in the squamous cell carcinoma exfoliative cytology, it depends upon the more morphological pictures are more atypical in exfoliative cytology of squamous cell carcinoma. But still, I think cytology is not a reliable tool to distinguish this both structures, both diseases. Okay, Dr. Samina has asked the spongiotic dermatitis can never have dyskeratosis.
No, spongiotic dermatitis can have dyskeratotic keratinocytes, but it's relatively uncommon. Certainly in an irritant contact dermatitis, you expect to see dyskeratotic keratinocytes. But you don't usually see lots of them, and they're usually not necessarily concentrated at the dermo-epidermal junction.
And Dr. Bushra Jamshed, you want to ask the question? Dr. Bushra Jamshed is thanking you for your nice presentation and so many other messages to me directly on my mobile. And Dr. Zahida Rani, Professor Zahida Rani. Professor Zahida Rani. Dr. Zahida. Okay. And any other questions?
Assalamu alaikum, sir.
Dr. Zahida.
Thank you so much for the meeting, sir. It's a really great pleasure to have you and looking forward to have more meetings like this. Thank you.
Dr.
Happy to do
Steven,
so.
we are both sitting here, dermatologist and the histopathologist. So this meeting is joint meeting to make collaboration between two specialties, because in my experience, even the dermatologist cannot make the diagnosis without a histopathology, and even histopathologist cannot make the diagnosis without a history.
That's
So
true.
when
There's
I
one more
was
question that showed up in the chat.
Yes.
How to distinguish between Langerhans cells and disc keratotic cells and atopic dermatitis? Well, in disc keratotic keratinocytes, you don't see a preserved nucleus. The nucleus is pink because it's dead. And in Langerhans cells, they have a preserved sort of reniform nucleus and a relatively abundant cytoplasm.
Thank you for excellent presentation. And sir, you are too for the opportunity to join this. Okay.
Assalamu alaikum, sir.
वालेकुम
Sir, I
सलाम।
want to ask one question.
जी 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 बिल्कुल आमों
Sir,
की
Dr.
पेटियां
Bushra
लगेंगी।
Jamshed is here. Sir,
Okay,
I
ask the
want to
question.
ask that usually when we get the biopsies in our setup, we don't get the history properly. So one thing which is very important to have from the clinician, or what is the specific note which we can add at the end of diagnosis, that one thing which is very important, if you can tell us.
A very important question, Dr. Bushra Jamshed.
Thank you, sir.
Well, I mean, yes, obviously, without clinical information, it's much more difficult. But, if you can at least get into a reaction pattern, and some things are very specific. Like if you see what looks like lichen simplex chronicus, even
Yes.
without a good clinical
Yes.
history, I think you can make a diagnosis. If you see lichen planus, I think you can make a good diagnosis. If you see spongiotic dermatitis, you could just say, spongiotic dermatitis, and the histologic differential diagnosis would include, all these forms of eczematous dermatitis. I do think you can make specific diagnoses even without clinical history some of the time, but certainly the more clinical history you have, the better your diagnosis will be.
Professor
Thank
Zaida,
you so
what
much,
do you
sir.
think, what are the difficulties you feel during your clinical practice?
Mine?
Dr. Zaida, what do you think
We have mostly we are confused with the final and diagnosing the malignancies, not the inflammatory dermatosis, because most of the time the clinical diagnosis is obvious in a lot of cases. It's where the certain papillosquamous disorders, they overlap, that we have a problem and then we get a biopsy done. But mostly, the dermatologists are more acutely aware of how to diagnose the
What
papillosquamous
type of
disorders
what type
clinically.
of neoplastic things do you usually encounter? Because I assume you don't see a lot of pigmented lesions like we do.
No, we don't see a lot of pigmentary malignancies, but we are able to see basal cell carcinomas and squamous cell carcinomas a lot in our areas.
in Pakistan?
In Pakistan, yeah.
Yes.
In my whole career for the last 25 years, I think I've seen 3 cases of malignant melanomas in
Oh,
total. But almost every other month, I see a basal cell carcinoma.
basal cells are more, yes.
Okay.
Basal cell carcinomas.
All right, good to know.
And
Yeah.
while other malignancies are also very rare, especially lymphoma of the skin, I have in my whole practice have seen 2-3 cases
Ajo.
total.
Yeah.
Okay, but especially in my practice when we are doing, I think it is difficult to
There were
even to
5 cases in the last 25 years.
yes,
Few of
yes,
my cases, yeah,
yes.
do have that
Okay,
here.
any other question?
Well, thank you for your attention and thank you for staying up so late.
Okay, Dr. Zaida, can you thank to conclude today's session because you are the host? Dr. Zaida, can you conclude today's session? And Dr. Samreen Hamid is also
Yeah,
here.
thank you.
Yes, sir.
Yeah, thank you, Professor Steven Billings. It was a pleasure to have you here and to hear you talk about the inflammatory disorders. I'm pretty sure that if we can collaborate with a pathologist, we both the specialties will learn a lot and become more knowledgeable regarding. Thank you, Professor Mulazim Hussain Bukhari, for your help teaching the dermatologist about the intricate details of histopathology. And thank you, thank you to the audience, all of them who are here
Inshallah, we'll meet you
in this
next
learning experience.
Wednesday. Inshallah.
Yeah.
Thank you, Professor Steven. I think before you come in Pakistan, we will have an introduction with you, and you will become very familiar with us, and you will feel what will be different problems, and so you will bring your slides and in workshops such type of the difficulties that we will face in these 3 lectures. Thank you so much. We all are waiting well in Pakistan, and inshallah you will feel Pakistan you are a home. Thank you so much. Thank you so much.
I'm looking forward to it, and we will schedule the next 2 parts of the lecture.
Inshallah. Thank you so much.
Thank you so much, sir. Thank you.
Thank
All
you
right.
so much.
We'll share this lecture to the group, inshallah.
Thank you,
fine.
sir.